Discuss a complex topic, so my goal is to really give you an update, maybe touch on some of the more controversial issues. What is the role of DAIR? Well, it's increasing. This is some recent data suggesting that more and more surgeons are using DAIR procedures. The growth in the utilization of DAIR seems to be predominantly in the early postoperative patient, the patient who's within 90 days of surgery. Now, it's difficult to make a lot of blanket generalizations when it comes to DAIR because this is a very complex topic. There's a lot of variables that go into the decision about whether or not to do a DAIR, as well as the outcome. So it's hard to reduce this down to a single factor analysis. We like to tend to do that in orthopedics, but you really can't do it when it comes to DAIR. There are some consensus statements as to who the appropriate patient is for a DAIR procedure. This is the ICM consensus on who and when to do a DAIR. And they suggested what I think a lot of us would accept to be a reasonable role for DAIR. It's the early post-op patient within 4 weeks of surgery and the late acute hematogenous infection. Their statement was that there's really no absolute contraindication to DAIR, but you really want to do it when you think the patient's going to succeed. And of course, that's easier said than done, trying to figure out who that patient is. And even in these consensus statements, you can see a number of people disagree. Now, the ICM put forth a number of factors they thought were associated with success. They had data to support these things. But if you look through the literature, there's really numerous things that have been advanced as factors that are associated with success or failure of DAIR: patient factors, surgical factors, technical factors, implant factors. How about patient selection? The ICM group advocated for these various scoring tools. The CLIC or the CRIME 80 were two that they suggested that surgeons could use to try to pick the winners from the losers.